Well, thank you for the invitation on this special day, on Duchenne Awareness Day. I'm proud to give you an insight into the psychology of Duchenne. And in line of the speakers in the morning, I'm going to discuss a little bit about how do we measure behavior, because when we decide to do something or not to do something, we have to know how we measure behavior. First of all, I have nothing to declare except for some research grants which we have from Duchenne Parent and from Spieren voor Spieren. And as Professor Verschuren said, we are part of the triangle in the Netherlands, which is called the Duchenne Expertise Center, between Nijmegen University Hospital, Leiden University Hospital, and the southern part, Kempenhagen and Maastricht. And we are working on the behavioral, the non-motor issues, the neurocognition. And I'm going to tell a little bit about that. And especially I'm going to zoom into the standards of care. First of all, what about learning and behavior? We did this search for publications and lectures on learning and behavior, where there was a theme in the keywords, and we found that in the last decades, there is a duplication of the number of publications on learning and behavior. So it's a theme that is growing in interest. And when you look at the history, it is actually very old, because Duchenne originally, in his piece on la paralysie musculaire, on his book about muscular dystrophy, he described 13 patients, of whom 6 had low intelligence, and 2 had a language deficit, and 2 of them had epilepsy. And when you go almost 150 years later, it is Valeria Ricotti who first introduced the term of dystrophin-associated developmental disorder. They did a research on learning and behavior issues. I will come back to that later, how they measure it. And they tried to find a relationship with dystrophin gene mutations. So there is again a triangle between behavior, muscle, and gene. And we discussed also in that journal about the diet between muscle and brain, which has important implications for diagnosis and for therapeutics. One example I want to show here, but there are a lot of research recently done, is very nice research by the Leiden group, where they did MRI scanning, studying brain morphology in DMD boys. And we also did some neuropsychological testing in the boys. And they found that there were smaller gray matter volumes and that the white matter showed reduced integrity. And on the neuropsychological part, which we are still investigating because of the boys of which we have scans, we know that some of them have reading problems. We are looking whether we can find a relationship between gene, learning behavior, and dystrophy. Okay, the standards of care, what do they say? Actually, I'm very glad that we have standards of care, and they improved very much when you look to the psychosocial aspect of care for Duchenne muscular dystrophy. So the psychosocial care, as they call it, should include a surveillance and the management of psychosocial aspects across lifespan, and it should also address this in different environments. So looking at home, at school, and at work. And it should not only consider behavior, but it should also take care of cognition and of intelligence. I will come to that later on. So the first step, and that's a very important and a very good step, is that they state that there should be routine mental health screening. And the mental health, they describe very broadly. And they have 4 instruments which they suggest to be used: the Strengths and Difficulty Questionnaire, the PARS, and for adult patients they have 2 other instruments. And these instruments are very easily accessible, and I did some research and I studied a little bit, and I show you some of the characteristics of these instruments. Because in psychology, Measuring is very important of knowing, but knowing is also important of knowing what you measure. That's also very important. And these are screening instruments. So they are not aimed of making a diagnosis. They are aimed at making a decision. Is the child at risk or is the child not at risk? And that's a very important and good step in the standards of care. This is the Strengths and Difficulties questionnaire. That's a very much used instrument, SDQ. It is from 1997 from Goodman, and it is a 28-item questionnaire which is about 5 domains. And it is aimed to identify boys at risk for mental health problems. And it has 5 domains, so emotional symptoms, the child has many worries, conduct problems, temper tantrums, hyperactive behavior, hyperactive behavior, overactive, peer problems, being bullied, and that's very nice of this screening instrument. It has a pro-social behavior scale. So that's very important in looking to behavior. When we look at behavior, we also tend to look at the negative aspects, but pro-social behavior is a very protective behavior. So it's very good that this is included in a screening instrument. There are norms about when the child is scoring abnormal or borderline, but these norms are only available for a typical population. So we don't know how the norms are for the Duchenne population, and we desperately need data for Duchenne to have a normative sample. There are 3 versions, that's also very nice of this instrument. There is a parent version from 2 to 70 years. There is a self-report version where the boys report it themselves, and there is a teacher report version. It's adequate reliability, it's good predictive validity, so in predicting things, and it is available in 85 languages. So it is the one questionnaire I know that is most used all over the world, and that has been translated into the world. And there are normative data of 10 countries, and you can easily access it via this website. And that's a good screening instrument. But beware, it helps not to make a diagnosis, but to make a decision whether the child is at risk. Another instrument that is mentioned in the standards of care is the PARS. That's a questionnaire of psychosocial adjustment. So how does the child adjust to stresses with which he is confronted? It was designed by Professor Stein from New Jersey in 1990, and it was made for children with a chronic disease. So it was originally developed for children with cancer, with diabetes, with epilepsy. So it was specifically made for children with a chronic disorder. And we start using it in boys with Duchenne. Again, 28 items, 6 domains, and these domains reflect coping. So they measure the way in which a child copes with difficulties. And probably you remember some of the things in how we people deal with difficult situations. One important scale is hostility. Hostility is an important way of coping with difficulties, but withdrawal also. Peer relations is again a supportive factor. So again, this is a questionnaire which is available, and we did research in 322 boys. We described those data, and we have now normative data of 1 sample. And this questionnaire is currently used in trials where also medications are used and other research on Duchenne. It is intended for 4 to 18 years, good reliability, and there are now translations into several languages. So it's available not only in English and Spanish, but also in Greek and in French and in Dutch. The other 2 questionnaires are questionnaires which are intended for adult populations. So that's a drawback of this. The generalized anxiety scale, 7 scales, 7 items, self-report, reliable and valid, trying to see whether there is a generalized anxiety disorder in the man with Duchenne. And the other one is the PHQ-9, 7. This is 9 items also intended for adults and intended to find out whether there are depressive complaints. Again, remember, it's screening, it's not diagnosis. The second step in the standards of care is about making the diagnosis. So when a boy is at risk, you should go and look whether there is necessity for further research, psychological care that's called. And they describe that neuropsychological evaluation should be done when the boy is at risk for developmental delay. And they also write down that some baseline neuropsychological testing should be done in the first year after diagnosis. I will come to that later. And also in the care considerations, there is a description of standardized evidence-based practices in relation to the stage of the disease. And then you see some standardized evidence-based practices like speech and language therapy, psychopharmaca, psychotherapy, developmental, neuropsychological, which are described, but they are not made concretely for how do we do that in boys and men with Duchenne. One thing that is mentioned in the standards of care, and it's the only psychological treatment issue that is discussed in the standards of care, is the medication, the psychopharmacological interventions, where it is described that standard procedures should be used for depression, for ODD, oppositional defiant behavior, and for attention deficit disorder. I will come to that later on. Okay, now let's mind the gap. What do we know? I gave you a little overview of what we know on learning and behavior, and it's evidence-based knowledge, and that's often scarce, and clinical practice is based on expert opinion, and we should take care of what is evidence-based. Let's start with intelligence. That's without discussion now. We know that intelligence is in the low average zone. When you look at one instrument, we did a review on the Wechsler scale, and when you look at the literature, very different scales are used. But when you look at one intelligence scale being used, you can find that performance IQ and verbal IQ is in the low average zone. This is the normal distribution. An IQ of 100 is normal, and between 58 and 150, that's a normal IQ. And what you can see is that verbal IQ is lower than performance IQ. And you might say, that's only 5 points. But we know that language and speech is an issue. And when I show you the next slide, you may understand why. This is a very nice research by Sue Cotton, although it is not a prospective longitudinal study, but it was a cohort study comparing different ages, but it is in a very large group, and it shows that the blue line, the blue columns, which represent language thinking, show an increase when they grow older. So at young age, you should take care of language problems, and that they are not motor-related language problems, and when they grow older, they grow out of a language deficit. So screening for language is, in my opinion, very important in early phases. Yet, I think that general intelligence needs to be reconsidered when we discuss about Duchenne muscular dystrophy, because until now we have no prospective data. All the data that have been reported are cross-sectional data, so we don't know how intelligence develops. It's my opinion, and in my clinical practice, we see that general intelligence may be an underestimation of the potentials, but yet we are not able to make this hard enough. But we are doing research on it, and there is more than a global deficit. So it suggests that in one intelligence score, you can characterize the cognitive abilities of a boy. That's nonsense. So we know that intelligence is about a very lot of neurocognitive functions. For instance, spatial thinking. How many blocks fit in this design? I'm a disaster in this kind of tasks, but I think it's 10. And this is spatial thinking. And we know that boys with Duchenne are fairly well in spatial thinking. So that's one of their strengths. But when you look at the weaknesses, these are 2 publications in the last 2 months on neurocognition. So it's a publication on digit span, which is working memory, and it's a publication on executive function. And when you start to read the literature, you see several terms and you start to think, what is it about? What's executive function? What's working memory? What's attention? So there is a lot of overlap between these weaknesses. I want to present this model of Purdy, and this is a very nice conceptual framework to understand neurocognition, and in my opinion this should be included in clinical practice, because this model describes that there are 3 functions, neurocognitive functions, which have an overlap, and then there is the working memory. Working memory is a core neurocognitive function. It is essential for your attention, it is essential for your executive function, and it is essential for your memory. And the relationship between those gives an overlap, so you can't distinguish them as we would like to understand it, but they have an overlap. So to give some illustrations, this is working memory. And in working memory, there is one thing, and that's called bottleneck. We know that working memory is a bottleneck. And the discussion nowadays is, are we able to increase the bottleneck to increase working memory? And this is, as I will show you later, one of the core problems of boys with Duchenne. This is about attention, so speed of information processing. And this is not motor related. This is just looking at the graph whether one of those 2 symbols is here, yes or no. And you have a few pages you have to complete, and you can see how quick a child completes it and how the speed of information processing is. And this is a very nice one. This is executive function, and this is illustrating when working memory, attention, and planning come together. This is the so-called zoo task. This is the Dutch version. I didn't have an English one, but the child has to make a plan in the zoo, and he has to go from the entrance here to the picnic there, and in the meanwhile he has to visit the apes, they are here, and the llamas, and they are here. And then the instruction is gone, and the child has to do it. So he has to have working memory, he has to make a plan, he has to rule his attention, and this illustrates nicely the model of Purdue, where all those things overlap. So it's not the point to discriminate working memory and attention and executive function, but we should look at them as something overlap. And as I told before, working memory is a core deficit. Several studies have been published now showing that working memory problems are related to Duchenne, and probably there is a relationship with DP140 or other gene things. Okay, this brings me to another thing, and that's automatization. So we have working memory, attention, and we have executive function, and then we have learning. How do we learn? We learn by working memory, executive function, and by attention, but we also need to automatize information. So learning to read and learning arithmetics has to do with automatization. So when you try to read this text, you probably don't recognize those signs, and you are not able to quick and automatic decode these signs into sounds. And that's reading. That's what reading is about. And what's going wrong in children with dyslexia, children with reading problems, is that they are not able to quickly and automatically decode these signs into sounds. Like this task. We can measure this in an easy way. The child has to quickly name all these letters, and we can measure in 1 minute how quickly a child is able to automatically decode these signs. 2 studies. We did a study in 2008. The Italian group did a study which was published in 2015. And the prevalence of reading problems in Duchenne ranges from 27 to 42%. And the population mean is 3%. So there is a higher risk, and we should screen for these problems. With respect to mathematics, we know that mathematics is about something different which has to be automatized, namely the number, the sense of number, the sense of amount. And this is a task which we administer in boards to see how quickly they have automatized number. You have to estimate the number of dots without thinking. It has to be automatized. That's what's essential for mathematics. And it has to do with the number, doing the counts, but there's no research on mathematics. It's our clinical impression, and we speak a lot of parents who say that mathematics is a problem, but we don't know about it. So we have neurocognition, we have learning, and we have behavior. And that's the third thing. The behavior stuff is about ADHD, autism spectrum, and obsessive compulsive disorder. And attention deficit has 3 core symptoms: inattention, impulsivity, and hyperactivity. And from the neuropsychology, from the brain, the main problem is that they have difficulty with inhibition, with stopping behavior. And when you look at this graph, there is something very striking in this graph. So these are 7 studies studying the prevalence of attention deficit disorders in Duchenne. And I hope you can see that there is an enormous diversity. But there is also one study, a recent study of Colombo, saying that the prevalence in their population was 0. So ranges from 50%, which I think is fairly high, to 0. And the Italian wrote, and I studied the article, especially for this talk, that they wrote that no ADHD comorbidity was found, and that the instrument they used the SDQ, which I talked with you. It's a screening instrument. It's not for making a diagnosis. May not be as useful as children with DMD cannot display the same type of hyperactivity. So there's a point which they make that we have to take care with the symptoms, but we have to take care with the risk of false negatives. So it has to do with the way you measure behavior. And there is no consensus in the literature on that. And there is now, in the standards of care, some consensus for the screening instruments, but how we make a diagnosis, that needs some work up. Because attention deficit is a clinical diagnosis. There are no biomarkers, there are no tests, so you need a protocol how to make a diagnosis. It has to do with behavior, and you can't measure behavior with a questionnaire. This is a questionnaire which is often used to illustrate it, the Iowa Connors, which is a screening instrument. Again, screening, not diagnosing. 10 items helping to see whether a child is at risk, but not making a diagnosis. Well, for autism spectrum, we have the same. Autism spectrum in normal population is in 0.5%. It has to do with 3 core clinical symptoms. I will discuss those extensively, but repetitive behavior, language impairment, and social deficits. And this is what the literature says on it. 7 studies, some of them the same as the ADHD before, but some of them specific on autism spectrum. And again, you see a very high diversity of prevalences. I looked at the ways in which the diagnosis was made, and I could have a very complete discussion with you, but just mention it, and we see that there are very different ways in which the diagnosis is made. And that explains why there are so different prevalences. And the third of the behavior issues, which is getting growing interest is obsessive compulsive disorders. 2 studies, and this is a very recent one published in 2018 of Angela Lee, in 107 boys, a prevalence of 15%. So again, something to take care of and something which we should take care of when we start to screen. Okay, what about the treatment options then? The treatment options are still in their infancy. And I showed this slide, and you saw that we try to see on the stage of the disease which interventions should be made. And these are the interventions that are mentioned in the standards of care, but they need some workup. We did report a case study on the effect of fluoxetine, which is an SSRI, an antidepressant, which is effective in obsessive compulsive disorder. And we are currently in progress of a study showing that methylphenidate is working also in Duchenne boys with ADHD. But it has not been published before, and we need knowledge on it before we can make some progress. With respect to working memory, we are very intrigued by whether we can train working memory. And in children with learning disabilities, it is now known that there are e-health computerized training programs that help to improve working memory. And that's, again, something which we should work on when we talk about the neurocognitive part. So the finish line is ahead. What are my conclusions? I want to introduce the term the Big Ten of learning and behavior. It's about 3 neurocognitive functions, which I talked about. It's about 2 essential learning problems, which are important, 2 emotional clusters, and neurobehavioral clusters. And step 1, as is described in the standards, is adequate screening, and step 2 is making a diagnosis. And we don't know what the golden standard is, but we know that when we measure, we have the risk of false negatives and of false positives. And physical limitations may result in false negatives, but they may also result in false positives. And what we do in the Netherlands is that, with help of the Duchenne Center, we are now forming a Dutch forum for psychologists and educationalists. And in the Netherlands, we are now having a forum where we discuss procedures and where we start to use the same instrument in making screening and in making the diagnosis. And it is my dream to have this worldwide, to have a worldwide forum of psychologists using the same instruments and doing it on the same way, because then we have data which can be compared. So to conclude, mind the gaps in our knowledge, beware of false positives and false negatives, make the distinction between screening and diagnosis. That's very important in behavior and in psychology. And develop a gold standard, and let's work together worldwide to make this the same. Thank you.